Hi everyone, thanks for tuning in to Inside the Training Room presented by OrthoCarolina. I'm Mike Moore with National Amateur Sports. I'm excited to welcome you to the debut of this new series. Over the coming months, you'll hear from sports medicine experts at OrthoCarolina as we discuss common athletic injuries and how to keep your student athletes safe and ready to play. Tonight, we're talking all things ACL injuries and meniscus tears, from the anatomy of the knee to injury prevention. Before we get started, let's get to know our presenter from OrthoCarolina. I'm here with Dr. Dana Piasecki, and a little later on, we'll hear from physical therapist Chris Gabriel. Dr. Piasecki is a former collegiate swimmer and water polo player and former Olympic flat water kayaker. He attended Vanderbilt Medical School and has some of the most prestigious orthopedic sports medicine training with his residency at the Hospital of Special Surgery in New York and Sports Medicine Fellowship at Rush University in Chicago. I want to remind everybody that you can put your questions in the chat, and we'll get to those at the end of tonight's presentation. Dr. Piasecki, welcome to Inside the Training Room.
Thanks for having me, Mike. It's great to be here.
All right. We want to talk about the ACL, a very common injury. If people, the layman knows about a common orthopedic injury, it's the ACL and the meniscus. But we're not going to assume anything, so let's get started. These injuries not only cost athletes time off the field recovering, but left untreated can alter the health of an athlete's knee permanently. I understand you do more ACL surgeries than any other physician at OrthoCarolina. How common is an ACL tear and a meniscus tear?
Well, so they're very common injuries. We all see these in sports medicine when it comes to the type of injuries that most athletes encounter, particularly the more common sports, all the sports that nobody can do right now with the whole COVID deal. Those are the sports that typically will cause ACL tears. So basketball, soccer, really any type of activity that involves changing direction can give you an opportunity to tear the ACL. And it probably happens more than we even see it in the office, but something around 200,000 athletes a year in the United States will end up with an ACL tear that requires a surgery. So it's a very common injury, one of the most common things we're looking for on the sidelines and in the training rooms for all the sports that we cover.
What's the importance of the ACL and the meniscus in the knee?
So the meniscus actually is more important than the ACL, believe it or not. The meniscus is a shock absorber. There's one on the inside part of the knee and one on the outside part of the knee. And the meniscus basically acts as the guardian of the cartilage inside your joint. So if you have the meniscus working the way it's supposed to, the cartilage stays healthy. And that's one of the main reasons we develop arthritis in later years in life. If you have an injury to the meniscus, you'll end up with an accelerated loss of cartilage and early arthritis. So the meniscus is really there to protect the health of the cartilage. The ACL is really important for two reasons. Number one is for function, and that's because you need that ligament basically to keep your knee from twisting on itself and giving out when you do a change of direction in a sport. Like if you're a soccer athlete and you pivot and change direction, if you don't have the ACL in your knee will give out on you. So you may not be as good a player if you don't have it, but it can affect people who are even just trying to keep up with their kids. You know, that you've got a young toddler who's trying to run away from you, and like mine were when they were little, they tried to beeline it right for the road and try to kill themselves at every chance you're trying to get to your kid, and you can't change direction. So the ACL is very vital for that. So function of the knee in terms of twisting. And then it's important for the health of the knee in a similar way as the meniscus, mostly because if you don't have that stability in your knee that the ligament gives you, and your knee is regularly pivoting in a way that it will, if you don't have the ligament, you'll often tear the meniscus. So the two are linked together, because if you don't have an ACL, it's almost inevitable if you're active that you'll tear the meniscus, and the meniscus, if you don't have it, will lead to arthritis.
Yeah, a lot of people think about the ACL and the meniscus as a short-term injury, something that happens, you get surgery, you fix it. But how can it affect an athlete long-term?
Yeah, so that is the biggest issue that we run into, actually. In fact, one of the main problems with this injury is it's very common in the initial injury phase. You'll have pain and swelling, but then it actually gets kind of better. It feels better. A lot of athletes will think, I just sprained my knee a little bit worse than normal, and now it's back to being its old self, and they'll they'll just continue and play through, even if it feels a little bit different. And the issue we run into, I guess, are those two issues that I mentioned about the ACL before, and that if you don't fix it, you'll probably take something off your performance long term. But more importantly, you'll put your knee at risk for causing damage, more damage to the meniscus and subsequent damage to the cartilage. So we see a lot of athletes who either ignore the injury or don't even realize they've had it, have early wearing out of their knee, and it shortens their careers, and it impacts their life well beyond sports into adulthood and all the things you want to do after you're done playing sports.
Is there anything that can be done to prevent those long-term effects?
Yeah, the best way is prevention. Prevent the meniscus from being injured further and stabilize the knee. So treatment for these injuries is definitely something we try to have an opportunity to provide for patients. So if we see athletes that are healthy, and really anybody who's active enough to injure the knee in this way is often someone who would benefit from having these things treated. And usually that ends up meaning a discussion about fixing these things to give them back the function that they need.
Yeah. If we watch sports, we see a lot of knee injuries happen from contact, from non-contact, all different ways. But how can an ACL or a meniscus injury occur, and what kind of injuries do you see most?
So the most common way that people will tear the ACL typically, and the meniscus will typically tear at the same time, is with what we call a non-contact twisting injury. So this is actually a pretty innocuous type thing. In fact, I'll see many, many parents each year with their kids who come in and say, look, nobody even hit them. I mean, they were just running down the field by themselves, and then their knee kind of did something funky and they fell down. It's usually not with a tackle or contact with another player. It's, again, that change of direction where you plant and try to move your body quickly, and that force goes through the knee in such a rapid way. If it strikes the ligament in just enough force, it'll cause it to tear. So this non-contact twisting event is what we typically see. And the classic explanation that patients will give us is, I heard a pop. And you'll hear pops all the time. I know, in our age group, we hear pops constantly, but this is a loud one. In fact, a lot of players who are nearby, teammates, will say, I heard it too. It's usually a pretty loud pop, and what's actually happening when that occurs, the ligament inside the joint is tearing, and you'll hear that noise. And then soon after that, the knee will swell. It's a very classic story. We'll hear, I was doing fine, nobody was even close to me, I felt this pop, searing pain in my knee, I fell down, my knee ballooned up with swelling, and that's a pretty classic story for tearing the ACL.
One of the terms I hear a lot sometimes is hyperextension. Is there a difference between a tear and a hyperextension?
So hyperextension is really what that's referring to, is the knee getting too straight. So you can tear the ACL in a hyperextension event, but if you imagine your knee is like, this is straight and this is bent, hyperextension is where it goes like that. So when the knee hyperextends, it actually can cause a lot of injuries to a lot of other structures. Really a hyper
They're still able to move around. How do they know when they should come in and get it evaluated?
Good question. I think swelling is one real sign that something significant has probably happened in the knee. And it's not just a little puffiness, but it's if you look at your knee and you're like, there's a watermelon in there. I mean, if it's noticeably, visibly bigger than the other joint is, then something, and you can even feel it. Some athletes will come in and be like, I can feel there's like a gallon of water in this thing. If it swells like that, you definitely need to be seen. And that doesn't necessarily mean that you've done something terrible, but it's a sign that something has been very irritated within the joint, which is not normal. So swelling like that, that's one thing. The other is if they have enough pain, they can't put weight down on the knee. That's your body saying you really irritated something badly here. Those are the two main issues. And then there are other obvious things. If you were to tear the meniscus badly enough, for instance, sometimes you'll get a little bit of tissue that'll get stuck in the joint, and your knee would be locked. I mean, these are obvious things. These are things my grandmother would say, you got to go. But the swelling and the pain are the two most common.
Okay. So it gets bad enough they need to come and see a doctor. What should they expect when they see you about the evaluation?
Well, we typically do. I mean, the first thing we do is try to get the story. What happened? Tell us how you injured your knee. What exactly occurred? What position were you in? what did you do? Because there's a lot of information we can get just from the story of how they were hurt. And I spent a lot of time trying to get that information because how you tear the ACL is different than how you might tear a tendon in the knee or another ligament in the knee. And that classic story is one of the things I'm looking for is a non-contact twisting injury. It's very common. So how did you injure it? And then we'll do a brief exam, and we're gentle. We're surgeons, but we're really gentle people too. We're not trying to hurt people, obviously. So we can figure out a lot just with a very gentle feeling of the joint, moving it very slightly, and examining the ligaments in a way that's not craziness. And then if we think it's indicated, we'll often talk about getting some imaging studies like X-rays or potentially an MRI. And those things together usually will allow us to tell patients, look, this is what's happened and this is what we think you ought to do about it.
One thing I'm curious about is, do you see a lot of these kinds of injuries in children that are maybe pre-junior high or pre-high school?
We do. We see ACL injuries are common across the board, but it's kind of interesting that you mentioned that. It definitely happens in young kids that are still growing. Even in like elementary school, we will see that. But actually, it's less common in those age groups than once you get into high school and college. And most of that is physiology because kids, when they're that young, and I tell my kids all the time, you don't know what it's going to be like when you get older. You just don't. I feel like someone should have told me that at some point. I never got that when I was a kid. But
Yep.
My kids, they're in their early teens and early adolescent years right now, and those kids, they're like rubber, literally. And if they fall and they break something, usually it just stretches. So they can have tears, definitely happens, but usually it's a sprain. So most of the time with younger kids, they actually have to work really hard to tear the ACL. Once you get into your 20s and 30s and 40s, if you do something that's aggressive, changing direction, it's a lot easier.
Yep, that's a good answer. So you've evaluated them, you've decided there's a tear, the meniscus is also torn, or maybe it's torn. What are the treatment options available to the patient?
So we always consider a range of treatment options. So I like to think that and this is true, I think, for all of my partners here at OrthoCarolina, we're surgeons, but really we're doctors first. Surgery just happens to be an option for treatment that we have to treat many of these things. And most of the people that walk in my door, probably 90%, don't need any surgery at all. And so the first thing we're thinking is, are there things we can do that don't involve any surgery? Are there treatments does this even need to be treated at all? Sometimes I'll see an athlete that's had a partial injury to the ACL where they've stretched it a little bit. They may have bruised the meniscus, but not torn it all the way. And we'll say, look, we don't need to do anything here. Let's get you to ice it, work with your trainer, and in a couple of weeks, they're fine. So not necessarily anything. Second option is non-surgical treatment. And sometimes in rare situations, if they've had an injury that's not bad enough to cause significant instability to the joint, we can actually treat them without surgery. There is a role sometimes for braces and for physical therapy to try to get them back in a way that's safe. And then the third option is of course surgery. And the truth is, for most complete ACL tears where the ligament is completely blown apart and the meniscus is torn, particularly for younger, healthier athletes, usually surgery is the best answer because we found non-surgical treatment, unfortunately, doesn't usually give them back that function that they need.
Can you talk specifically about grafts as a treatment?
Yeah, sure. So yeah, you'll see a lot about this. What you're describing there, a graft is basically, it's a piece of tissue. And when we go and actually reconstruct the ACL, which is the surgery we do to fix it, we can't repair it because it doesn't have the ability to heal inside the joint. So a lot of patients will ask, well, why can't you just stitch the ligament back together? And it just doesn't work well. The ligament doesn't have the ability to heal. So the treatment for that, the solution that we found that works really well, is to actually remake the ligament. That's what's called an ACL reconstruction. And the way we do that is using a piece of tissue that's basically the same size and same strength as the normal ligament would be. And we have to get that tissue from someplace. That tissue is called a graft. And we can get it from basically two main places. We can get it from a cadaver, somebody who's died and donated their tissue to medicine, or we can get the tissue from the patient themselves. Um, and we usually like to lean towards, there's been a fair amount of evidence over the past number of years that using tissue from the patient themselves, which is what's called an autograft, tends to work better, particularly for younger active patients. But allografts, or the tissue from a cadaver, as they're called, those are options as well.
And what kind of different surgeries are available for treating this, from a, arthroscopic to full blown, surgery and opening up the knee?
Well, you can do it. There are a lot of ways to skin a cat, as many of my mentors, when I was training back years ago, would say. There are lots of different ways you can do these operations. The way that is the most standard way that has been shown to have the least amount of complications and get patients back the quickest is what's called an arthroscopic approach. That means we're using a camera to look inside the knee, as opposed to making a really big, huge incision and opening up the joint. Good results have been reported with the open approach, but that's really not standard of care now. Most of the time, unless there's an extenuating circumstance or a really significant additional injury involved, we'll almost always do it arthroscopically.
Okay, and the last question I have for you is, talk about recovery time after surgery or arthroscopic procedure. How long does it take for a patient to recover and then be back at full strength?
So the recovery time, the quick answer to your question is it depends a lot on the athlete, but it's usually somewhere between 6 and 9 months. They're back doing everything. If it's an aggressive sport that is high risk, so something like football or soccer, or basketball, where they're doing a lot of jumping, the main rate limiting step actually is not healing of the graft or healing of the things that we do in the operation. It's actually getting back the muscle strength and coordination those athletes need to protect their knees from another injury. And that can happen as early as 6 months, but it may take as long as 7, 8, or even 9 months. And the more we learn about ACLs, the more we're learning that going back slower is usually smarter. So it's not that we make patients or athletes wait an unnecessary amount of time. We're very careful to fine tune it to the athlete, but being careful and being safe, we found, is the best way to make it a one and done deal. We don't want to do any surgery if we don't have to. If we do it, we only want them to have one, and we want it to work. And we want to get them back and do everything that they need to do and not have problems. So usually 6 to 9 months is the answer.
So what are the elements that post-surgery that go into a successful recovery for an athlete?
Yeah, so I think first is expectations, understanding what their problem is and why they're having a surgery, and understanding how long that recovery is, and then going through the different phases of it with eyes wide open and being a full partner in the process. It's a team effort, and I'll often have patients thank me for the surgery when they're done, and really I feel like it's a team effort. Everybody's in the boat together, and most of all the athlete is. So the best successful recovery after the surgery really has as much to do with the athlete as it does the surgeon. And that early phase where most athletes are in a brace for a period of weeks and they're seeing a physical therapist pretty regularly, understanding this is important because I'm optimizing my recovery later. So it's really being on the same team as all of us together. But that early phase, and then we take them all the way through, and we're right there with them, arm in arm, till we get them back out there on the field.
All right, terrific. Dr. Piasecki, do you have anything else you want to add about this subject?
No, it's great. I love it, though. I will tell you, this is my passion my passion are my patients, but I love ACLs. I tell patients all the time. My wife gets on me because I have a real passion for this surgery. I probably do, I don't know, 60, 70 different operations, something like that. But this is the one that really literally gets me up at like 2 a.m. thinking about ways to innovate and change and make it better. And so it's a real privilege to be able to offer that to my patients. It's fun.
All right. Dr. P, we appreciate your time today. Thank you.
My pleasure. Thanks so much, Mike. Have a great day.
So we want to welcome Chris Gabriel, who is a sports physical therapist at the OrthoCarolina Sports Training Center. How you doing today, Chris?
Doing great. How are you, Mike?
I'm doing good. Just a minute ago, we talked to Dr. Piasecki about treatment, surgical treatments and rehabilitation for ACL and meniscus injuries. Your angle is to talk about injury prevention. So tell us some more about that.
Yeah, as we heard from Dr. Piasecki, these injuries are very serious, involve a lot of downtime and a prolonged recovery. So our goal in the rehab is not only to rehabilitate the people after the injuries and surgeries, but our ultimate goal is to really prevent these injuries from happening in the first place. So there's been a lot of great research that's come out in the last several years that really can assist us in making sure we're directing our efforts appropriately.
So what are the best parts of an injury prevention program? What are the goals there?
You can think of it, a lot of times it's used as a dynamic warm-up program. So it's helping the athletes improve their agility, their quickness, and a lot of technical aspects. How they jump, how they land, things of that nature can really go a long way in minimizing the injury risk.
And these are things that athletes can do in preparation for a game as part of their warm-ups, right?
Yeah, absolutely. That's a lot of what we do. We'll actually teach the athletes the injury prevention program, a part of their rehab. They'll do it as part of the rehab, so when they leave us, they have the injury prevention program. They understand how to use it, and we encourage them to take it back to their coaches and teammates and make it a part of every practice.
Okay, so how do you assess athletes and give them exercises to do for injury prevention?
There's a lot of different things we can look at. There's some quick screens we can use in addition to our normal physical therapy screen. I like to just use some easy things that coaches and athletic trainers can do in the training room. One simple thing to do, which is my first video here, is just a simple 4-square test. It's a plus pattern drawn on the floor, and you're just going to ask the athlete to jump back and forth around the diagonal of that cross pattern. And we're just looking for things like, how do they land? Are they soft? Are they bending their knees symmetrically side to side? Or are they kind of shifting weight one side or the other? And another thing we look at is knee valgus. Do those knees kind of buckle in? I think Dr. Piasecki probably talked a little bit about that, and that's a huge injury risk. So we have the first video where the athlete's jumping on both legs, and then we can make that a little harder, asking the athlete to jump on one leg at a time, and then we can compare symmetry side to side.
And after you look at these videos, are you able to customize kind of a warm-up routine for the athletes?
Yeah, absolutely. We'll plug in certain exercises based on how they look in that jumping and landing video. If we want to get a little more advanced, there's a couple different drop jump tests we can use. One we use a lot in the clinic is called the landing error scoring system. And basically it involves the athlete jumping off a box that's 1 foot in height. We're going to ask them to jump off about 1 foot away from the box, and we're going to assess how they land. There's a grading system that we give a score of a 0 for a good movement, low risk, and then a number 1 is giving for a poor movement or a high risk, and then we assess their injury risk based on that. So if you look at the next slide, first thing we look at is the knee valgus at initial contact. Are their knees buckling in? You can see in the first slide up at the top there, athletes landing pretty symmetrically, the knees are apart, but as he sinks down into flexion, you can see his right knee kind of buckles in and he shifts to that side. So obviously this is something we're going to red flag as an injury risk pattern that we want to try to put some corrective strategies to avoid. We'll also film the athlete from the side, and one thing we look at is when their feet first hit the ground, are they landing in a little bit of knee flexion? You've probably seen a lot of videos of athletes landing with their knees too straight. Their knee could buckle, hyperextend. So we want the knee to be in a little bit of flexion, as in that top photo there. And then in the next section, we want them to bend at least another 30 degrees so they're absorbing that force. And the final thing we look at is there a loud sound upon landing, or are they landing soft? The softer they land, the more gradually and softly they absorb that force, and it does cut down on the injury risk.
Yeah, do you find that that girls versus boys need different kinds of exercises?
Yeah, absolutely. Girls and boys do land a lot differently. Obviously, there's exceptions for different genders, but we do see a lot of issues where the girls don't quite absorb that force as readily as the boys. There's many different reasons for that. And then we also see injury risks in different groups. You know, we'll do a lot of screens for not just ACL injuries, but for all populations. And one thing we really see with the ACL group, especially after surgery, they tend to shift that weight away. So if you see in the next slide there, you can see that they want to land a little more on their non-surgery leg and avoid landing on that surgery leg. So a lot of speculation for that. It could be they just don't trust that quad on the side. It could be a neuromuscular control issue. So we do Try to identify these risks.
They've stretched it a little bit. They may have bruised the meniscus, but not torn it all the way. And
want to try to put some corrective strategies to avoid. We'll also film the athlete from the side. And one thing we look at is when their feet first hit the ground, are they landing in a little bit of knee flexion? You've probably seen a lot of videos of athletes landing with their knees too straight. Their knee could buckle, hyperextend. So we want the knee to be in a little bit of flexion, as in that top photo there. And then in the next section, we want them to bend at least another 30 degrees so they're absorbing that force. And the final thing we look at is there a loud sound upon landing, or are they landing soft? The softer they land, the more gradually and softly they absorb that force, and it does cut down on the injury risk.
Yeah, do you find that that girls versus boys need different kinds of exercises?
Yeah, absolutely. Girls and boys do land a lot differently. Obviously, there's exceptions for different genders, but we do see a lot of issues where the girls don't quite absorb that force as readily as the boys. There's many different reasons for that. And then we also see injury risks in different groups. We'll do a lot of screens for not just ACL injuries, but for all populations. And one thing we really see with the ACL group, especially after surgery, they tend to shift that weight away. So if you see in the next slide there, you can see that they want to land a little more on their non-surgery leg and avoid landing on that surgery leg. So a lot of speculation for that. It could be they just don't trust that quad on the side. It could be a neuromuscular control issue. So we do try to identify these risks, especially with the girls, but squatting task, as you can see in the picture here. It's just an easy way to build some strength, and again, we can watch how stable they are on their leg. Sometimes our athletes really have trouble controlling that, so we try to give them some kind of an external cue to where maybe they're asking their knee to track down on the line. I have a video here of an athlete doing a squat just using a laser pointer, tracking down along a line, and it really helps the athlete understand how much that knee is wobbling back and forth side to side. And then we look at symmetry. We really want them to be symmetrical side to side. Core strength is really important for this group as well. We're all familiar with plank exercises. There's several different options here. Front planks with a leg raise, and then side planks. Getting the core and hips strong is really crucial for these athletes to get back to sport, and it's good to use as part of the warm-up. We look at more posterior chain, thinking about glutes and hamstring. Bridge progressions really work well here. You can do a single leg bridge with hip extension. You can get a little more creative and use what you have available. Doing a single leg bridge on a soccer ball, maybe rolling back and forth, is really a great way to get the core and hips engaged. And then lunges, very basic movement pattern. I have a video here of a young man doing some walking lunges, walking lunge with some rotation, walking lunge with a little trunk lean. So these are really good ways to warm up the lower body, encourage proper movement patterns, and get the body ready for practice or games. If we want to get into a higher level exercise, this is a Nordic hamstring curl, and basically I'm holding the athlete's ankles, asking the athlete to slowly lower down. This is a great eccentric strengthening for the hamstring, has been shown to minimize our risk of hamstring injuries as well. We do have some folks that aren't able to do this well on their own, so we give them a little cheat and let them roll out on a physio ball.
Nice. A good set of exercises. How long would it take somebody to go through these as part of their warm-up?
In general, most of these injury programs are designed to be, around 10 to 20 minutes. Usually it's a little closer to the 20-minute side. Coaches have limited time in practice, so we want to make sure that this is something the athlete can get in a reasonable period of time. During the therapy phase, as folks are learning this, it's going to take a little bit longer, but as I say, we try to incorporate these as part of the therapy session so that when they're done, they know these exercises, they can knock them out very efficiently.
Great. So once again, if you do have questions for Chris or Dr. P, please put them in the chat. We'll get to them after we finish these presentations. Chris, the next thing we want to talk about is plyometrics and jump training and how that helps prevent injuries.
Yeah, great. As we've developed, some of the more basic core strength, lower extremity strength, we get into jumping and landing plyometrics. We want our athletes to be explosive, but we also want them to absorb that force well so they can land safely. We'll start off with some very basic, just doing a jump squat here. I have a video of this. We can do this on single leg, double leg, just looking for the athlete to land softly, not drifting into valgus. We can do some really basic just line hops. We go back and forth over the line. We can go side to side over the line. We can do one leg. These are just some very easy ways to do it. And then if you are doing this at a practice situation, it's really easy to line up a group of 20, 30 athletes across a line, and you can very easily scan down and see who has good movement patterns and who doesn't. So if you do have a big practice group, if you are just doing some screens, this will give you a lot of information pretty quickly. The next video here is of something we see a lot. It's just the young lady's having trouble controlling her knees. You can see how her knees drift into a little valgus as she jumps and lands. So that would be somebody we'd identify and try to find out reasons why that's going on, probably start some hip strengthening to minimize her drift into valgus. Scissor jumps are another one, just getting reciprocal. We have him jumping back and forth on the line, making sure he's absorbing that force nice and gently. And again, not drifting into valgus. So very easy exercise to do, gets warm up. Now we're going to go into some rotational jumps, asking the athlete to just jump out and kind of rotate in the air 90 degrees. And then they can also work on drifting out and rotating 180 degrees. There's plenty of instances where we get knocked in the air when we have to adjust our body in the air. So we don't always have a really planned jump. So it's nice for the athletes to be able to rotate, still learn how to land in a proper movement pattern. Bounding is basically defined as a one-leg takeoff, landing on the opposite leg. A lot of these programs will have some components of bounding. Again, soft landing, want to make sure that's nice and stable. In the clinic, we'll do a lot of bounds onto a Bosu to where you're kind of landing on an unstable surface, really challenging the athlete to have to stabilize that force and work on a much higher level. Lateral bounding is just going off to the side. We like to use this a lot on our athletes, such as baseball players, people that need to do a lot of side-to-side motion. First video just shows bounding back and forth. The next video, the athlete's tethered to a sport cord. So not only do they have to use extra force to explode out against that resistance, they actually have to stabilize and stick that landing while the cord pulls against them. So nice extra challenge for those athletes. You can get a little creative, add some hopping. This next video is 2 hops into a bound. Makes them do something a little more that they'd have to do on the field, a little more complex movement. Again, asking them to stick that landing, make sure they're nice and stable. You can do the same thing laterally. 2 lateral hops into a bound. It's also great for conditioning as well as warm-up.
And then it seems like the next step is to get into more agility and change of direction as the athlete gets stronger, either from post-surgery or is just they work through their program. Take us through some of those exercises.
Yep, exactly right. Everybody's interested in getting back to cutting. We see a lot of folks that want to get back to cutting full speed or really do some high-level drills maybe they had done before injury, but we want to make sure they're cutting with proper mechanics before we put speed. There's a few just basic tenets we take a look at when we look at change direction. We want to teach the athlete to do this at a very slow speed initially. And 2 concepts to keep in mind are kind of center of mass and base of support. So basically you want to keep your center of gravity, which is usually just below your belly button, over the base of support. So when they're changing direction front to back, we want to keep the nose over the toes, as you can see in that first picture, and in a nice athletic stance, making sure they're bending their knees. And then when they go side to side, you want to make sure the athlete's leaning in the direction they want to go, and again, drop the center of gravity. A lot of times as athletes get tired, they don't want to use their quads, they don't want to squat down and get low, so they tend to cut in some high body positions, and then that leads them to injury. So we'll just look at them going front to back. I'll just have them do some basic back pedal and front to back change of direction, just in a 5-yard stance. And then we're just kind of looking at how they move. If you look in the picture here right beside the video, you can see the gentleman's pushing off, but once he pushes off, his knee does drift into valgus, which basically means his knee is going inside of his foot. That puts him at a big risk for ACL. So that's a common movement pattern dysfunction we see, and we want to clean that up. Several different drills we can do to encourage that. One is, again, using just an external focus, something they can focus on, such as bringing their knee to a cone or a line, as we saw earlier. We can do a drill, which is a split squat resisting valgus pull. So basically, he's doing a split squat while this sport cord tries to pull him into that valgus position. So he needs to use his quads and his hip muscles to maintain that proper knee alignment. And if he can do this as a drill standpoint, we'll have confidence that eventually he can do this as when he's doing his direction change, when he's doing his running. Next video just shows some lateral change of direction. And again, we're asking him to keep his center of gravity over his base of support, not going into knee valgus as he goes side to side. The next advancement we do is looking at some 45-degree change of direction. So I have a couple research studies cited here, and basically what we're looking at is just the athlete running to a point and then veering off either to the left or the right at a 45-degree angle. And this is a pretty interesting research study. They looked at the athlete and they gave them several different cues of how to move. And they found that when the athlete's torso was leaned away from the direction of the cut, and when they had a wide foot placement, as you can see in a couple of those photos there, it put a lot of extra stress on the knee. So what that means for us is we want to encourage what can be considered a whole body sidestep cutting technique, to where the athlete's foot is not too far away from the direction change point there, and they're also getting some lean into that direction they want to go. And that will really minimize the risk. And it's really important as we're teaching athletes to cut after their ACL reconstruction surgery. We understand that there's going to be situations on the field where we might not always be able to cut in proper form. But if we at least encourage some of these less stressful movement patterns, it can really encourage more efficient movement on the field and really cut down our injury risk. I have a drill here. This is just a simple T drill. I have a few cones set up. I'm going to ask the athlete to sprint down to the middle and then just break off to one side versus another. Incorporates forward, backwards direction change, as well as some side work. And this is a really nice drill we can use a lot in the clinic. I'll have athletes have to react, catch a ball. They can respond to verbal cues. So just to mix it up a little bit, make the athlete think on their feet.
So that's a lot of drills to go through. So post-surgery, what is the progression that you put patients through and the timeline before they get all the way to cutting drills?
Yeah, that's a great question. It's a long process after surgery. Most of our folks aren't starting to jog until about 4 months. Once they develop some proficiency there, we'll have asked that they pass some different balance tests. And then by the time they get out to around 5-6 months, we start some of this stuff very, very gently. Light, small jumps. We start the direction change stuff even at a walking pace or a jogging pace. It's really low stress at that point. And then, by the time they get to around 8 or 9 months, we're starting to talk about passing these tests and getting these athletes back in the field. I think the key is that it's not just a passage of time that helps these athletes get back. They have to go through the tests in a logical stepwise progression at very, very slow speeds at first. We see a lot of folks come in and they're 7-8 months out from surgery, whatever the case may be. They just want to start full speed cutting. They want to go on the field. But if you haven't done any cutting at controlled speeds, and if you haven't passed any of these tests at lower levels, you're really not safely able to do some of these things at full speed, because when they get out on the practice field with their teammates, they're going to want to be going full out and showing off for their coaches and their teammates. So we need to make sure that they've done these things in a controlled manner before we turn them loose to full speed.
Yeah, so if people want more information about the preventative part of your program or how to get some training, what should they do?
I've included a slide here that lists 3 of the more common injury prevention programs you've probably seen nationally. We don't advertise for one program versus another. There's many pros and cons of all the different programs, but PEP program, Sports Metrics, and FIFA has a lot of good online resources available, as well as videos. You can tailor it to your team. And then, as you saw in one of the earlier slides, there's really no one injury prevention program that's been shown to be the best. So I think as long as we're incorporating some of those different components, you can tailor a program that really meets the needs of your team or your athletic group.
And can somebody that's interested talk to a physical therapist at OrthoCarolina too?
Absolutely. OrthoCarolina.com has access to all our different therapists at different sites. A lot of great information and experiences out there. So we're more than happy to help out any way we can.
All right, Chris, a lot of great information. So now it's time to get you to your questions. So let's bring Dr. P back and answer some of what you got. All right, we are back after the presentation here and ready to bring in our panel to answer your questions. If you do have questions, please put them in the chat here. I'm joined by Dr. Dana Piasecki. Chris Gabriel is here with us, and then Margaret Lynch, a new face, who is a physician's assistant, easy for me to say, at OrthoCarolina. So the first question we have is for Chris. How often does an athlete need to do preventative exercises to see a benefit?
Most of the research recommends they're done about 2 to 3 times a week. So most programs can be done at the start of practice. So that's really an easy way to get it done consistently. But definitely 2 to 3 times a week. And we really try to start that in the preseason phase, just so they can get a good build up to the program to have done it about 6 weeks in total to start seeing some benefits.
And a follow-up to that is should a football player wear a protective knee brace when playing?
That's a great question. I'll kick that to Dr. Piasecki first or Margaret, and then I can kind of chime in after that. But I think knowing those folks, we're pretty much on the same page with this one.
So, Mike, the issue there with the brace, it's a controversial issue. I will say, if you talk to the brace companies, they'll tell you everybody on the planet ought to have a brace. The data is a little bit mixed. And when you really look at the studies, when it comes to bracing, there are a couple positions on the football field that may have some slight improvement in injury risk, but not necessarily for the ACL. It's usually for the MCL, actually, which is a ligament on the inside part of the knee that will heal fine, usually without surgery. And most of the linemen you'll see out there with braces, they're trying to prevent that type of an injury. But there's very little good evidence out there that wearing a brace when you play football or any high-risk sport actually prevents an ACL tear. But you do see a lot of brace use in the NFL. You see a lot of the coaches swear by braces. And so there may be an effect that we're just not seeing in the studies much, but I don't routinely recommend that athletes wear a brace to prevent an ACL injury.
Margaret, you have anything to add to that?
Yeah, well, I was a former athletic trainer before I became a PA, and bracing typically resulted in spending money, and then shortly thereafter, a quarter or so into the game, the brace would end up on the sideline with me. They're bulky, they're kind of heavy. Linemen, it was kind of a little bit like a security blanket, I think. They felt like they were a little more invincible in those, and so that may be some value, but for the most part, I would say that most braces are costly and then not widely used for a consistent amount of time.
I would say one comment on bracing, though. I think, while it's not been shown that bracing has not been shown to prevent injury, it can sometimes be a nice little psychological boost for the athlete and the parents to feel like, this is going to help us get back. It's not necessary from a biomechanical standpoint in terms of the knee, but there is a little bit of a confidence boost that sometimes does come with a brace. So it's not a bad thing. But I agree with Margaret. It's not mandatory for everybody, and most people don't need it, but it can help a little.
Yeah, I see in college, almost across the board, you'll see offensive linemen wearing braces. It's like their coaches require them to. So let me ask you this. Will an athlete need a brace after surgery, Dr. P?
So that's a little bit controversial too, I'll be honest with you. Many different surgeons have many different approaches to that. Most of us do use bracing on some level, and I personally like to use a brace, which is a different brace than the one you might consider at the end of their recovery. But I do use a brace in the first 6 weeks or so afterwards. And it's actually not to protect the ACL graft, it's to protect the patient from themselves, because most of these athletes and really any patient that's had an ACL, the recovery is not miserable in the beginning, but it puts you down for a couple of weeks, and then you start feeling better, and you're often inspired to do more stuff than you should. I'll have my patients in my age group, they watch Chariots of Fire. You know about that movie, right, Mike? Chariots of
Yeah.
Fire. I
Oh
tell
yeah.
my
Oh yeah.
tell my younger athletes about that, and they're like, "What are you, 90?" Like they have no idea what I'm talking about. But you watch an inspirational movie early on, and you get inspired to do more than you're supposed to do. And so the brace sometimes it's a little checkmate. It pulls you back in and says, "Look, I just had an operation here. I got to be kind of careful." So there is a brace, at least for me, I recommend using a brace in that early month and a half period after surgery.
Yeah, Chris, what is your experiences with with athletes using braces post surgery?
I think in the immediate post-op phase, I think it's fine as long as you're encouraging the athlete to come out of the brace, do their exercises, things of that sort, and really focus on getting their quad back. So I think as long as they're motivated to be consistent with their exercise and realize they just can't lay in the brace all the time and let time magically heal everything, I think that's the point I want to make. And then as far as bracing after return to sport, the thing I'd maybe add is a lot of people get a false sense of security when they have the brace, or they say to themselves, hey, I know I'm not 100%, I know I haven't passed all the tests, but just give me a brace and I can go back out there. And that's really not how it works. You still have to work just as hard. You still have to get your quad back. You still have to pass the tests. The brace isn't gonna make up for that. So the decision with a brace is a controversial one, but we still have to get all the strength back. We still have to pass the test, regardless of whether we choose to have a brace or not.
Yeah. Let's change subject. Go ahead, Dr. P.
No, I was just going to say those are great points. I think that's very true. I mean, everybody wants a quick fix and they want to get back in the easiest way possible, which there aren't any shortcuts in terms of effort and also time. It's one of the things we've learned a lot about recovery after ACL surgery. There's a lot of time involved, and there's a lot of time after you feel like you should be able to do it that you can't do it yet. And what we found in the studies looking at some of the return to sport parameters is a lot of athletes feel like they're ready to go back, even 6, 7, 8, 9 months sometimes, and actually they're not. And that's why seeing a really good physical therapist like Chris to really help with some of those maneuvers you saw earlier, so they can figure out, hey, look, I may feel good, but my knee's just not quite ready yet. Fastest way to go back in the beginning is to go slow, so that then you can go fast later.
Okay. Got a question in the chat from Finley. It says her 13-year-old son just tore his ACL playing baseball. What would be your advice as far as surgery saving the growth plate versus waiting until he's older? He's very active.
Yeah, good question. So the issue with growth, the things that you're balancing there when it comes to kids that have open growth plates, you're balancing whatever growth they have left against the potential they're going to have another injury or cause damage to their knee if they play without an ACL. And when we've looked at that issue in young active kids, usually it's far more costly to not have surgery than if you do. So what happens if you just leave the knee alone and wait until the growth plates close, you tend to have more injuries, usually to the meniscus. In fact, probably about 90% of kids in the first year after an ACL tear that are adolescents like that will, if they ignore the ACL tear, and even if they're trying to hold back from doing aggressive things, will tend to have some type of abnormal twisting of the knee without that ACL in there, and they'll have a meniscus tear. And the meniscus, we know, as we talked about before, is very important for protecting the cartilage, and that can have really long-term implications for the rest of their lives, not just playing baseball now, but playing baseball with their own kids later. So the recommendation usually in active kids is to think about surgery. So there are ways you can manage the risk to the growth plates. And really, I think for most kids, particularly for boys at age 13, it depends a little bit on how mature their skeletal growth is. But there's probably not a ton of growth left. I'm sure there's some, but right around the knee, oftentimes there's not a whole lot of growth left at that age. There's some, but enough that you can work around the growth plates or even do a special type of ACL reconstruction going through the growth plates to protect them in a way that minimizes the risk of a problem.
Okay. And Finley asked another question. After alternative surgery, do they need to go back in and have a regular repair when he gets older?
So what I think the reference there is to there are two main approaches out there for dealing with the growth plates. One of them is to do actually just a normal, very well done ACL reconstruction, similar to what you would do if the patient was an adult. And the other is to do what's not really an anatomic reconstruction of the ACL. You kind of work around the edges and do a reconstruction that's not totally normal. At age 13, I think the argument would be to go for the real ACL. And what we find is that if you do a good job with it when you have 2 years or less of major growth remaining, which most 13-year-old boys do, they've got a couple years left, but it's not like they have 8 years of growth left. Usually, if you do a good ACL in that situation, you don't have to do it again. And if you do the alternative, which is kind of working around the edges, not really reconstructing the ACL, but putting a lot of restraints on the knee so that you just can't really be as active as you would otherwise be, that sometimes does require additional surgery in the future. So probably the best way to deal with it, in my opinion, usually if you're at that age, is to do just a really well done, careful, thoughtful ACL reconstruction.
Okay. Let's shift gears a little bit. I'll start with you, Dr. P, and then get to Chris and Margaret. A lot of people, or maybe it's an urban legend, I hear that teenage girls have more knee injuries than teenage boys. Is that true? And why do you think that is, if it is?
Well, specific to ACLs, it's definitely true. And if you look at the numbers of ACL tears that are out there, girls are probably up to 3 or 4 times more likely to have an ACL tear than boys. And there have been a lot of theories about why that is, whether there are some differences in the anatomy of the knee or if there's some hormonal differences that make soft tissues more loose jointed. And there may be something to that, but I personally think it has less to do with those differences and more with activity level. And we know, speaking even more to what Chris has really emphasized with how important the balance of muscles around the knee is for minimizing the forces that the ACL will see. I think it's the fact it's activity level probably that makes the biggest difference. So if you don't have the muscle balance to minimize the forces that go through the knee when you're active, you're more likely to tear an ACL. And I think the differences that we see mostly in adolescent high-risk sports like soccer, for instance, is that when girls are going through that developmental phase, they tend to put more forces through their ACL than boys do, bottom line. It's not like some problem with female ACLs. It's a physics issue. But we definitely do see it. And that doesn't mean girls shouldn't play those sports. Those are great sports. But it underscores how important it is to really focus on getting those muscles strong and balanced before the season starts so that you can minimize the risks.
Yeah, Chris, from your standpoint, with girls versus boys, what's the difference in the preventative and then the recovery?
Yeah, it's definitely a big issue we see with a lot of injuries with girls. You know, they tend to land with a little more valgus to where their knees buckle in. So not that boys don't do that to some level too. That's why it's important to screen everybody and see how they actually move. But getting the hips as strong as possible, hips and glutes, hamstrings and quads, all those muscles are really essential to decrease some of the stresses on the knee, regardless of the literature and back and forth, what factors are important. We want to make sure we're getting the muscular system and also the neurological system in terms of balance and motor control optimized to minimize these injury risks.
Margaret, what's your experience with this being an athlete?
Well, so, I mean, definitely soccer teams that I was on, I was one of the few people that didn't tear their ACL. But as an athletic trainer, too, seeing the ACLs come through, I think there are a couple of factors that play into it that they all talked about were the muscle imbalances. I think you also have to factor in a little bit that the females are going through some body changes at that time that predispose them a little bit to these muscle imbalances. And then also, as an athletic trainer and teacher, I used to catch girls. They love to stand with their knees hyperextended and locked. They shift their weight over to one side, jut their hip out, which kind of perpetuates, it tells those muscles, hey, I'm on vacation, I don't need to work. And then when you put them back into activity, like Chris is asking or talking about doing, I think it kind of predisposes them to a little bit of those injuries.
And how much of a role do hormones play when we're talking about girls' injuries?
Well, I think we don't know, right?
Yeah, we don't know. No, we don't know. I mean, there is some theory that estrogen and progesterone, the primary female hormones, have an impact on looseness of joints. But it's kind of weak. I mean, the problem is, like, you're seeing a rise in those hormones at the same time you're seeing these high level activities being played. and girls are going through growth spurts and dealing with all the forces that go along with high risk activities. So it's tricky to prove that there's an issue. And my personal suspicion is if there's an effect there, it's probably pretty small, and that most of it has to do with just, as I said before, just the physics, and that you're cool if you're a girl, play soccer, it's good for you.
Okay. Getting back to surgery, is there ever a circumstance where an athlete may want to delay surgery and play through the season? And what's your advice on that?
Yeah, that's a tough one. That's controversial. I think it really comes down to, and we're kind of making decisions about this every time we talk to patients, which is a balance of risk and benefit. What is the risk of playing with an ACL tear balanced against the benefit of finishing out the season, let's say. And that has a lot to do with what we know happens if you don't have an ACL tear and you play. It depends on the sport and the athlete. Most of the time, in my opinion, usually if you balance those factors out, it tends not to favor playing with an ACL tear because we know that it puts the meniscus and the cartilage at high risk. So, but it depends. I mean, you may have an athlete, I'll have athletes who are training for the Olympic Games and they're ready to go. It's Olympic trials, and it's a lifelong training approach they've taken, and maybe their activity, their sport is not super high risk, change direction type stuff, and it may be worth it to go ahead and play with that anyway. But if it's you're a sophomore and it's a couple games left in the season, and it's you're not even sure you like playing soccer, I'd probably recommend sitting out, getting it fixed, and not doing any more harm. So the answer is it's a balance. We always try to make a thoughtful decision for patients. It's not a one-size-fits-all approach. And we do try to balance how eager athletes are to get back, but we're balancing giving them a safe, healthy knee for the rest of their lives too. And that usually, most of the time, will outweigh the benefits of a partial season going back, at least in my opinion. But it's a tough call. We take it one patient at a time when we make those calls.
I used to always remind athletes that when we're young, we're writing checks that our bodies will cash in later. And you want to make sure that it's worth it, because it's easy when you're 15 or 16 to make a decision because you are seeing the next month or two. But then when you're 35, 40 and you're dealing with the issues that came about, you gotta kind of weigh those risk benefits.
Mm-hmm. And I would say, I think that's a really good point. I mean, I think obviously, we make decisions for younger athletes with their parents in consultation. But when you look at what you see in our practices, we have the opportunity to see patients from young all the way through all different phases of life, all the way up until their 70s, 80s, and 90s. And that looking back for many of these patients really is something that they often will say, hey, look, I wish I hadn't done that, or I made a bad decision doing this. And those implications really do have a lifelong effect.
Chris, from a physical therapy standpoint, what's your view on delaying surgery?
Yeah, I think Dr. P hit it on the head. You've got to really consider the cartilage and the meniscus issue. A lot of people don't understand that. They think, well, my ACL is already torn. What else can happen? And they don't understand how hard it is once you destroy the cartilage and the meniscus. You're never the same. So, we want to protect that as much as possible. But again, it is a judgment call. And as long as everybody has all the information on the table, Margaret and Dr. P do a great job educating patients on this. If they make a thoughtful decision with their parents and the athletes and everybody knows the risk, I think there are some situations, whether that is a person we brace, whether it's somebody we take through a few functional tests to make sure the ACL, they can compensate for it with the neural system and muscular strengthening to make sure that, we're just not sending them back out there, make sure they do have some baseline control. Because it can make a big difference in a professional athlete, certainly a higher level athlete, maybe the last few games of the senior season where they're not going to play in college. So there are judgment calls, but in general, I think protecting the cartilage, people need to understand how important that is.
All right, very good. Dr. P, one last question for you. Do you think one graft choice within an autograft is superior?
So just a little background on that. I think we covered a little bit of this before, but as a review for the folks watching, you can get a graft is the tissue we use to make the ACL with, and when we do an ACL reconstruction, we're basically replacing the old ligament, making a new one. So the places you can get that graft tissue from a donor or from your own knee. If it's from your knee, there are a couple different choices of what you can use. The tissue that seems to work the best most of the time, in my opinion, this is another controversial issue. You take 10 sports surgeons and you put them in a room, you're going to have 10 different opinions on this. But my personal approach is that the patellar tendon graft, usually, if it is an option, tends to be a better option most of the time. And that's because it tends to give a more stable normal knee at the end of the full recovery, and it has the lowest re-tear rate still after 50, 60 years of these surgeries. It seems to be rising to the top every time it's looked at. But that doesn't mean there aren't other great options, and you can use a piece of your quadriceps tendon or your hamstrings. You could make an ACL out of almost anything in the body, truthfully. And if it's your tissue, there's a reasonable chance it would work okay. Excellent results have been reported for a lot of grafts. And so there are a lot of really good choices out there. I think it's one of my mentors in fellowship told me, this is back 15 years ago or so, said the type of graft you use is like the color Porsche you drive. And I'm not a car guy. I'm not into cars at all, actually. But, that underscores that most of these athletes are healthy, they're motivated. And if the surgery is done correctly, the majority of grafts will work really well. But my personal opinion, if I tore my ACL, for instance, I'd use the patellar tendon graft, because I do think there's some subtle benefits there that it's not for everybody. Sometimes a hamstring will be a little bit better of a choice, but there are small differences.
With the exception, like the one he was talking about, a better choice is like if the Finley that has open physes or growth plates, with those, typically you'd pick the hamstring graft for those.
Yeah, that's correct. I mean, there are issues that would make other grafts better. And Margaret's right. When we have open growth plates, one of the ways that we can deal with that and still do a one-time ACL that should last and work great is to use a soft tissue graft instead of the patellar tendon. The patellar tendon, tiny little piece of bone on both sides of it. And that's one of the reasons it works really well in adults, is it heals quickly and securely, versus the soft tissue grafts, which are like a tendon that's put in the bone, and you ask the tendon to heal into the bone. It can be just a little harder to get the healing. But if you balance that against the growth plate issue, for younger kids, a hamstring graft tends to be a superior choice in that situation.
All right, terrific. Well, guys, we're out of time. Want to thank everybody for tuning in. Dr. P, if somebody wants to make an appointment to come see you, how do they do that?
Well, if you just call OrthoCarolina and just ask. I mean, we've got a lot of great sports providers there. Of course, I'm one of them, but there are lots of us in our OrthoCarolina Sports Medicine Center, and I think it's just you can look online actually and schedule an appointment through our website now. So just go to OrthoCarolina.com, and there's a phone number there as well as a way to access our appointment scheduling digitally.
Chris, what about you if somebody wants to come in and get an assessment?
Yeah, really the same thing, OrthoCarolina.com. It's really easy. You can search all the therapists in your area, and it's pretty easy. Just go through the website, and we'd be happy to take a look at you and help out however we can.
All right, guys. Well, thank you for your time tonight. Thank you for everybody that tuned in and watched. We will continue this series in the coming weeks, so keep your eyes open for it. If you have any suggestions about topics you want to hear about, please put them in a chat. And panel, thank you a lot, and we will talk to you later.
Thanks, Mike.
Thanks, guys.
Thanks, everyone.